for inviting me here, and I guess we're on the home stretch. The title was already given. Much of this work stemmed from work done on small caliber vascular grafts, where we were trying to bypass diseased vessels of the body. And this slide goes back to 1984, and it really has not changed since then. Our goal was to make a bypass graft to bypass diseased vessels of the heart. And the technology that we worked with was a spinneret, which you see over here, and we have 30 fibers coming out of it, and the fibers and spinneret were moving to the right, and they go back and forth hundreds of times to build up a porous matrix. And if you take the porous matrix and you pull it off the vascular graft, off the mandrel, you have this vascular graft with controlled porosity. And this is the fibers over here relative to a human hair. So they were 20 micron fibers and maybe 20 micron pore size. And we used a material that is still used for pacer lead insulators. It's a polyurethane called Polyethylene 80A. And we found after 1 month, these fibers all cracked. And very hard to get a company financed when that happens. So what's happening? And the mechanism was worked out by Jim Anderson's group at Case Western. Your granulocytes, or macrophages, leukocytes, etc. They come to your polyurethane material, which is in motion, and they secrete superoxide and hydrogen ion, and the pH can go down as low as 1. And small molecules get cleaved off as the material begins to flex, and as it flexes and embrittles, it begins to crack. And we're left with this cracked substance that I showed you a little bit earlier. What I found very intriguing was you had a huge inflammatory reaction that attracted polymorphonuclear leukocytes. And if you follow it, you'll see foreign body giant cells. And if you look at it in different areas, you can see phagocytosis of polyurethane fragments. And the more of these granulocytes that were attracted, the larger the capsules were that formed around the implant. So the theory was that the long-term foreign body reaction is a function of the inertness and cleanliness of the polymer. Any chemical release causes an inflammatory reaction and exacerbates encapsulation. So there's a need for a new elastomer that is totally biostable in superoxide and pH 1. And for those of you who use silicone rubber is not stable at low pH. It tends to depolymerize and release a cyclic molecule called D4. It's the precursor to silicones. And this is one of the problems that occurred with the shutdown of the breast implant industry, which happened about 15 years ago, was because of the uncontrolled release of D4, which was believed to be steroidal. If you had such a material, you can now use it against metals, and metals cause metal ion oxidation, and you can use it in sensitive tissues of the body and as microscaffolds. So the strategy is really simple. You get rid of all bonds that are capable of cleaving in the body, and I was going to apologize for getting into the organic chemistry, but after what I listened to the last 2 days, I don't apologize anymore. So you have to get rid of ethers, esters, amides, urethanes, ureas, carbonates, carbon-carbon bonds, and double bonds. And for those of you who have worked with polymers, there's really not much left. So here's the theory, and it's very simple polymer chemistry. The simplest of the polymers is just thousands of carbon units in a row, and this is polyethylene. In the presence of macrophages that secrete their superoxide and bring the pH down to 1, you form free radicals on the backbone. And the free radicals begin to conjugate. And if you have a single bond, if you imagine 2 pieces of wood with a nail through it, you can rotate the pieces of wood. But if you put 2 nails through it, you can't rotate. And this is what happens in polymers. If you have double bonds, you can't rotate. And this manifests as embrittlement. So 10 to 30 years ago, they used to make polyethylene acetabular liners that go between the femur head and the acetabular cuff. But they found that they began to oxidize. And people began to publish on this, and it was really these macrophages in the body that were oxidizing polyethylene. So nowadays it's very difficult to find an acetabular liner. So if you go to the more complex polypropylene, now you have a tertiary carbon connected to 3 carbons. Bring out your macrophages, you can still form your free radical, and you can still embrittle the backbone. And this is what happens to the proline suture with time, and this is the reason you can't use proline sutures for haptics on IOLs. And there are publications on that by Gene Goldberg that go back to the mid-80s. So proline also oxidizes and embrittles. Get a little bit more complex now where you have the quaternary carbon. Here you have 4 carbons connected. Bring out your macrophages. Maybe you can get a free radical on the backbone, but with steric adherence, it's very, very difficult. But you're never going to form double bonds on the backbone because carbon can never have 5 bonds. To form a double bond, you have to cleave a carbon-carbon bond, and that does not happen in nature. So you will not oxidize polyisobutylene. That's called polyisobutylene. And if you don't oxidize, your macrophages don't come around. They certainly don't stick around. So we make this in our laboratory, and we synthesize a seed molecule, and at minus 80 centigrade, we put a plus charge on each end, and this is called living end carbocationic chemistry, and the mechanism of reaction was licensed from Joe Kennedy's lab at the University of Akron. So we infuse in isobutylene, which is a gas. It condenses at minus 80, and we form this reaction, and we can stop it on a dime. So now you have chewing gum. And if you want to convert a gum into an elastomer, you either have to crosslink it, which we just learned about, or you have to vulcanize it. And the very fancy Pirelli tires are vulcanized polyisobutylene. But the vulcanizing agents are toxic and can't be used in the body. Plus, they load it up with carbon black. If you want meltable crosslinks, you put in crystalline sections or glassy sections. So let's say we stop this at 800 links. If you put in a glassy polymer like polystyrene, you can now form these crystalline segments, and we can stop that reaction on a dime. So what we have are crystalline bundles that are meltable that connect these amorphous rubbery strands. So we form these elastomers, and this is called polystyrene block, because there's a block of polystyrene, isobutylene block, and another block of polystyrene. So what's neat about this is there are no cleavable groups on the backbone, and there's no cleavable groups on the side on the sides of the polymer. And we found that the tissue interface and the biocompatibility was very different than what we've seen before. Now, by controlling the amount of polystyrene, if you put a lot of glass in or a lot of styrene, you have a very hard material, and it's like brush bristles. If you put in very little styrene, you can make things like gummy bears. And why am I saying gummy bears? Because you'll see when I talk a little later about intraocular lenses, you can flow these fully formed lenses through a small cannula. So we looked at it over 2 years as stent grafts, and we found that there were no sections identified that showed any granulocytes. And it was a very benign reaction, very different than anything we've ever looked at or that the pathologist at sick kids ever looked at. We also looked at little fibers, and after 2 years, we saw no cracking. And if you want to measure molecular weight change, you just plot, if you have a decrease in molecular weight, it means your polymer is degrading. But we showed over 2 years in contact with metals that there's no decrease in molecular weight. So it's a very stable polymer, as expected. So the first use of this was as the carrier for the drug paclitaxel on Boston Scientific's drug-eluting coronary stent called Taxus. And if you don't know Taxus was the largest product launch in the history of medical devices. Sales went from 0 to 3 billion in the first year. And the cornerstone of making that work was the SIBS polymer, which was coated on the wire, and the SIBS polymer carried the drug paclitaxel. And it's important because it did not encapsulate. If you use other materials, and they tried many other materials, they would encapsulate and the drug will not be released. So when you develop a product for a company that does that well, they kind of like you. So I asked them if they would license me back my polymer because they bought my company and I'd like to try it in the eye. And we were close to Baskin Palmer Eye Institute. And they did some work where they put discs of the SIBS into the cornea intrastromally, and they found that there was no neovascularization. It was very well behaved. They also put it subconjunctival, but they had controls of silicone rubber discs. This is polydimethyl siloxane that are used in the Ahmed and Behrvelt valves. And in these discs, you get neovascularization. You get myofibroblasts that cause scar tissue formation, and you get a lot of de novo collagen. So you form capsules around silicone rubber. However, with SIBS, they found no neovascularization, no myofibroblast, and no capsules. In fact, when they dissected the eye, these polymers just fell out. They were not where they left them. And if you look at histology, you'll see around silicone rubber, you have 200 micron capsules, whereas around SIBS, you have it's a very loosely bound layer, around 20 microns of just cells. So the goal at InnFocus was to achieve, to make a device to achieve the same results or better as trabeculectomy, and a procedure that any comprehensive ophthalmologist can do in half the time with minimal post-surgical follow-up. So we, after a few trials and some preliminary clinical studies, we made a tube that had fins on it, 100% out of SIBS, a very floppy material, very small. This is it on my finger. So we matched the compliance of ocular tissue, conforms to the curvature of the eye. It does not require a cadaver patch. It's a soft, flexible, rubbery. There's no erosion. You have atraumatic fins, and these atraumatic fins prevent migration and periannular leakage. There's no metal, so there's no MRI interference. The outer diameter is 350 microns. It actually can fit in the lumen of the Behrvelt tube. The lumen diameter is 70 microns, and we derived the lumen diameter from the Hagen-Poiseuille equation. However, we had to kind of tune it because we're very hydrophobic. We had to go larger than what Hagen-Poiseuille predicted. So if I can, let's see if I can get this working here. No, that's not going to work. I'm trying to get a movie, so let's go back up one. And I'm not sure how to do that, but let's see if I do it this way. Okay, let's see if that goes. And normally it comes up over here. So I'm going to do this outside of. Oh, neat. So I lost the image. Let's go back and go into screen resolution. Apply. Keep changes. Okay. Back here. And let's see if I can, come on. All right, so this is Isabelle Riss in Bordeaux, France. So what you do is you form an incision in the limbus. This is a fornix-based flap. Dissection under the flap. And we use Mitomycin C in the United States. Over here, you have to put it in with pads because it's not FDA approved otherwise. You make a mark about 3 millimeters below the limbus. And we use a little knife to make just a little pocket over here. And these are going to hold the fins. So it's about 1 millimeter wide, about 1 millimeter deep. And now she just changes magnification, so you have to bear with me here. Put a needle tract in, that is 25 gauge needle. And it goes into the anterior chamber. And we can't put it in with an inserter because the fins are too big. So you take the device just with a forceps, and it's pushed through this needle tract And the fins are pushed in, and they serve like a cork on a bottle. It keeps fluid from coming around it, and it keeps it from migrating in any direction. She'll check it for flow, and she'll put it underneath the conjunctiva and just put a couple of sutures on it to close the conjunctiva. Okay, so let's go to the next one here. And come on. Oh, good. Okay. So if you look at the plot of intraocular pressure with time, you want to be in a zone between 5 and 14 millimeters of mercury. This is the Aegis zone of no progression of vision loss. So our population of patients began with a fully medicated pressure IOP of 23.6. And here you see it progressing over time. So we're holding a pressure of roughly 11.3 millimeters of mercury over 3 years. And we're waiting for more of our N value to increase with time. Just looking at the data at year 3, we have a 94% qualified success rate. I talked about the pressure being around 11. Uh-oh. And we also have a reduction in meds to about half. And this is just some pictures showing that it's really benign. And here's a patient at 5 years with 2 of them in, because if one fails, you can put another one in. So we also make intraocular lens out of that. Why do you need a new lens? Because with femtosecond lasers, you can make smaller incisions. We need some with lower cost of goods for third world countries. We need materials that can be used in pediatrics, and we need to stop glistening and whitening. And we need larger lenses to prevent dysphotopsia. And also, if you have a rubbery lens, perhaps you can get accommodation. So our reaction was changed to put in a cross-linking group, and this is a cyclobutene on the polymer backbone that's under a lot of stress. You put 2 of these together, and when in the presence of heat, they open up, and you can bond them and cross-link together. So we were able to make the right intraocular lenses. We can put in UV blockers. We can control the modulus from gummy bears to stiffer. We ran rabbit studies at University of Utah. There's no whitening or glistening. Tissue reactions were similar to Microsoft. We can go through very small incisions. We also, because we have no byproduct and no polar groups, nothing that can come off, we can stop the whitening or glistening reactions that occur with the acrylics. The glistening in acrylics is due to the presence of initiator. When you polymerize it, you trap them in there. You also have inconsistencies of homopolymerization of some of the ingredients for acrylics. So if you were to extract lenses, which is often done with intraocular lenses, you can pull out the soluble particles, but you're left with voids that fill with water, which causes glistening and hazing. The insoluble ones stay there, but they swell differently, and this becomes the area where you also get water entrapment and glistening. Also, polymers tend to hydrolyze with time, and here you see the N groups. If you put an OH on SIBS, it'll turn it to white with water. So just 2 molecules in the molecular weight of 60,000 is enough to do that. So SIBS has no cleavable groups, but the acrylates do. And you know from organic chemistries that esters aren't stable in water. And they will tend to hydrolyze and you form the acid group. And this is another source of long-term whitening of intraocular lenses that occur. And it's irreversible. And this is what you see on the right. These were taken out of patients. So SIBS-based medical devices will continue to show less inflammation than other known elastomers. SIBS-based microshunts in the eye function well. The InnFocusMicroShunt has stopped glaucoma progression. We may eliminate the trabeculectomy. It's expected to move upstream to avoid the long-term complications with glaucoma medications. The preservatives are really causing damage to the conjunctiva. And the IOLs are going to get smaller, less skilled to place. The cost is going to come down because of injection molding. And this is my talk. Thank you.
Okay, thank you for your beautiful presentation. We have space for question? Yeah.
Hi. It's a common complication of lumen
They lead to hypotony, and hypotony can lead to RD and so on. How do you prevent hypotony with these shunts?
Well, the diameter of the lumen is 70 microns and is very hydrophobic, and the length of it. So that diameter tends to drop pressure, so it's not supposed to go under 5. In reality, we have 3 patients that hit 5 with which you would call hypotony, but they cleared up spontaneously. There were never any adverse events in the over 100 patients already tested.
And with a 70 micrometers diameter, you never have any problems with clogging, granules, or any kind of debris?
No, we looked at the endothelial cell sizes, and the maximum that you can find is maybe 40 to 60 microns. So at 70, we've never had a problem with clogging. We've never seen that, actually.
Dr. Pinchuk, what is the length of the tube?
8.5 millimeters.
Yeah, I assume that your device is in the aqueous humor. Is it?
It's shunting from the anterior chamber to a bleb under the conjunctiva tenons.
Okay, so is it possible to have aqueous humor get in touch and can diffuse in?
Well, aqueous humor goes through the lumen and fills the bleb and diffuses into the episcleral venous system, or through the conjunctiva, and we think it's more through the conjunctiva.
Okay, and can you deliver drugs through it, or is it just the device?
You can deliver drugs through it, and there's a possibility of binding drugs to it or mixing it with drugs, as we did in the drug-eluting coronary stents.
Okay, so that's also a possibility then. You can have both controlled by the device as well as by the drug. So.
Yes, we can. It's just another $500 million to get through the FDA.
Change.
Question about the elastomer. So what's the elastic modulus of your material compared to the conjunctival space?
What's the elastic modulus of the material compared to the conjunctival space? Well, I can give you a number of what the modulus is. It's roughly about 100 pascals. It's very soft, and we can control it. Compared to the conjunctiva, if you hold it an 8 millimeter tube of ours on one end, it'll be limp. It won't stay straight. It's different than silicone rubber, which wants to go straight. So it's very soft. I don't know if I answered that correctly. Yes, sir?
What is the contact angle of water dropping?
It's been a while since we measured it, but I believe we measured it at 36 degrees.
36 is hydrophilic.
I'm sorry?
36 is hydrophilic.
Oh, this is very hydrophilic. There's not much that's more hydrophilic.
Because I thought you said it's hydrophobic, and that's the reason that you can go.
No, I'm sorry. It is hydrophobic, and 36 is the. I see what
above 90 degrees is hydrophobic, and super hydrophobic are close to 160.
Oh, okay. I see what the problem is. It's 136.
Okay.
Sorry, I left out a digit. It's been a long time.
So, is that going behind the iris or just above the iris? And
it bisects the angle between the cornea and the iris.
So, never complication, any kind of itchy or any kind of complication showed before?
We've had some cases of corneal touch. Sorry, not corneal touch, of iris touch.
Okay.
We never had corneal touch, and we measure endothelial cell loss in our U.S. IDE study. We have 12 centers now testing it in the U.S.
That's great. Wonderful. Very nice.
Thank you.